All right, so our second speaker is Dr. David Gregornik. He is the Pharmacogenomics Program Director at Children's Minnesota, so one of our local speakers. Dr. Gregornik, this is a bit of a homecoming, attended the University of Minnesota College of Pharmacy, where he earned his Bachelor in Pharmacy and his PharmD. After graduating from the U, he completed specialty training in Pediatric Pharmacotherapy and Pharmacokinetics at St. Jude Children's Research Hospital in Memphis. And currently, Dr. Gregornik joined Minnesota Children's in August of 2016, where he has established a pharmacogenomics clinic and is implementing a clinical pharmacogenomics service in both the inpatient and ambulatory care setting. So please join me in welcoming Dr. Gregornik.
Thanks, Jacob, for that introduction. And as Jacob said, I'm the Pharmacogenomics Program Director here at Children's Minnesota. We have established a clinic where we evaluate patients on a referral basis who have had either medication misadventures that were unpredictable, adverse events, or multiple therapeutic failures, and are working with them to try to get pharmacogenomic testing as might be appropriate. Here's some standard disclaimers that Children's Minnesota requires, and I will be discussing off-label use of medications, as this is frequently the case in pediatric pharmacy. Objectives today, we're going to identify some characteristics that make pharmacogenomics unique in children. And then we're going to, again, look at some CPIC guidelines and recommendations and a study that looked at FDA labeling and pharmacogenomic information in pediatrics. And then I'm going to walk through how our group reviewed and implemented the CPIC guidelines for Citalopram at Children's Minnesota, which, again, would be an off-label use in some of our patients. Medication considerations in children, there's actually more use of medications in children than one might think. 60% of children receive a prescription medication annually. 25% of those children have a chronic condition, so those frequent flyers account for about 70% of pediatric prescriptions. So there's a high use of medications in children. Children, as pediatric pharmacists know, are at an increased risk for adverse drug events for a number of reasons. Most drug dosage forms are actually designed to take for adults, so we're having to do half tablets, create suspensions, figuring out how to get a medication into a child. We're frequently, again, extrapolating adult information into the pediatric into pediatric usage, and we don't have a lot of good evidence then about drug exposure and how drug exposure affects a child as opposed to an adult. So we're working kind of in sort of a little bit of a gray area as we extrapolate this information. ADEs are an important risk factor, depending on which study you look at. ADEs rank between the 4th and 7th most common cause of death, and they result in an excess of $177 billion in excess healthcare costs in the U.S. And a couple of studies have demonstrated or postulate that up to 60% of adverse drug events may be associated with genetic variants in drug metabolizing enzymes. So pharmacogenomics does play an important role as we evaluate medications for children and trying to avoid adverse events. So how many pediatric pharmacists do we have in the room and have seen this picture? Not that many. Okay, so this is something almost all pediatric pharmacists deal with on a day-to-day basis. There are multiple developmental changes, changes in GI function, changes in gastric pH, changes in GFR as we age. So we, as pediatric pharmacists, are always moving or having to think a little bit out of the box and adjusting our thought processes about drugs and thinking about development in our patients. And so we're going to talk about a word here called ontogeny. We're going to, and so developmental pharmacogenomics or ontogeny, Merriam-Webster defines ontogeny as the development or course of development, especially of an organism. So with respect to ontogeny of drug metabolizing enzymes, this is one of the most important factors for the differences we see in children, is the impact of maturation on drug disposition. This has a direct effect on systemic exposure of a medication. The first example, or one of the classic examples of ontogeny, was with the drug Chloramphenicol. When chloramphenicol was given to neonates, we identified the gray baby syndrome. Babies' skin color changed to this gray appearance. They ended up with multi-organ failure and sometimes went on to a death due to toxic chloramphenicol concentrations. More recently, we've identified that the drug metabolizing enzyme, phase 2 enzyme, UGT2B7, was the cause of this. It's immature at birth and does not mature until later in life, and so chloramphenicol is sort of the classic example of ontogeny effects in patients, in pediatric patients. So when we look at the ontogeny of drug metabolizing enzymes, we have sort of three patterns that we can see. Across the bottom, we have a timeline. Across the bottom of this graph, we have timelines, so beginning at conception all the way through adulthood, and then percent of adult metabolic activity on the y-axis. And so the first pattern is sort of a constant pattern. It develops during development prior to birth, and it's sort of a constant pattern for CYP3A5 and TPMT. And we have this sort of steady metabolic pattern through adulthood. The second pattern we see is sort of a high activity level during development, and then a real quick drop-off at birth, and then sort of low activity levels during childhood and into adulthood. CYP3A7 and SALT1A3 are examples of that. The most common or largest pattern we see is that actually the fetus lacks a lot of metabolic activity and then very quickly attains metabolic activity shortly after birth, frequently exceeding adult metabolic activities and then dropping off to adult levels with the onset of puberty. So we need to have our genotype and phenotype relationships aligned if we're going to use pharmacogenomics, because we need to have those relationships, or they're not fully apparent of what a genetic interaction might be until the gene product is expected to be fully expressed. These are just some examples of 5 of the CYP enzymes. Several of them are negligible at birth. We have some low activity at birth for CYP2C9 and 2C19. And then just different postnatal activities. We can see that we attain adult activity a little bit later or at different times for each of these enzymes. Just to look at it graphically, again, we have birth on the bottom all the way through to age 10, and then percent of adult activity. And with increasing maturation, we can see the increases in percent of adult activity. So at birth and through the first 25 years of life, this is an example of one gene with multiple individuals, and it's sort of a hypothetical construct for how we can think about the development or the ontogeny of enzymes. But we can see early on 2 different phenotypes that can develop, and so poor metabolizers are expected to, throughout the entire life, just remain poor metabolizers. But the quick rise, and we can see that we have a lot of variability in the normal metabolizers, or and some due to genetic variation, some not. But early on, we can see that indistinguishable, or the poor metabolizers really are indistinguishable from normal metabolizers at birth. After ontogeny, we need to consider the disease states that we are looking at. Pharmacodynamic effects can be different with the different disease states, and pharmacogenomics can play a role, or a different role, depending on what we're trying to treat. There's some diseases that are more prevalent in children than adults. Persistent pulmonary hypertension, which we treat with sildenafil, obviously would have a different pharmacogenomic response than treating ED in an adult male. There are several pediatric diseases without an adult correlate, such as Kawasaki disease. We've heard a lot about clopidogrel and CYP2C19, but we use clopidogrel in treating or preventing thrombosis in children with Kawasaki disease, and we really don't know how the genomic effects might work in that arena. And then there are diseases with similar names but have different presentations between children and adults. Hypertension tends to be renal in origin with children, and it's very different than the essential hypertension that we see in adults. So when we approach the evaluation of a gene-drug pair in children, when can we expect our genotype to predict our phenotype? This paper describes, in the research realm, 4 questions that you can ask as you are trying to evaluate this in developing medications for children in the drug development process. But they apply, I think, as well to what we can look at when we're looking at this clinically. And that's an evaluation of the disease states and how similar they are between children and adults, which genes are important for the drug of interest, are genetic variations in the gene associated with the functional consequences in vivo, and what is the developmental profile for when we can expect functional activity to be attained. I'm going to return to this when we come to the implementation review in the last part of my presentation. Looking at CPIC, when they can, will evaluate the pediatric information and put some statements that are in there into the guidelines to cover pediatrics. And so for ondansetron, Jillian, who spoke this morning, noted that there are no data available for CYP2D6, but there's no reason that we would not expect a child to respond any differently with CYP2D6. And ondansetron metabolism. But we do note that neonates, it's immature at birth, negligible function at birth, but does very quickly attain adult activity. So children less than a month old, we might need to think about our use of it, but after a month, we can apply these guidelines. SSRIs, CYP2D6 and CYP2C19. There's scarce pediatric data again, and so these recommendations should be used with caution in children and accompanied by close monitoring. And then when there's no data, as in SLC01B1, they note that there's no way to predict how any genetic changes would occur with myopathy within pediatric patients. I just went back and looked, and for the last 5 years, we had close to 70 patients who received simvastatin at children, so this is something that we can look at, or need to look at, and try to evaluate for evaluating myopathy in our patients. There's one study out there that evaluated or summarized FDA drug labeling and pediatric information related to pharmacogenomics. They identified 65 drugs with pediatric labeling that included pharmacogenomic information. Of those 65 drugs, as we would expect, 56 of those drugs, the data was derived from adult studies, leaving only 9 that were informed by pediatric studies. Further review of the FDA guidelines, 40 of those drugs they decided were suitable for pediatric patients. 16 they decided were unclear, with the reasons for them being unclear were ontogeny effect, limited or conflicting data in pediatric studies, or there were adult-specific disease states. Moving on to Children's Minnesota, we are the 7th largest freestanding pediatric health system in the U.S. We have 2 campuses, one in Minneapolis, one in St. Paul. We have 12 primary care clinics, 2 emergency departments, and 9 specialty care sites, and 6 rehab sites, and we are trying to bring pharmacogenomics to all of our outpatient sites as well as within the hospital system. One of the first things we did when we started building our program was we created a Pharmacogenomics Oversight Committee. This was, I ran around to interested parties within our medical teams. Of course, pharmacy was involved. And we built this oversight committee that helped us develop our policies and procedures and provide insight into our implementation. Coming from the oncology world, I needed to reacquaint myself with a lot of general pediatric information, and so having this multidisciplinary group within the medical teams really helped as we develop things outside of the oncology world. And then we report quarterly to our P&T committee, so we report up through hospital structure, but we are an official service and committee within the institution. To date, we've implemented in our EHR and our clinical practices 3 genes and 16 high-risk medications. TPMT and the thiopurines was our first implementation. We thought that we'd keep the impact small, being that it was just sort of the GI groups that were using the thiopurines as well as our hemonc group. And so we sort of got our feet wet with that. Then we expanded to include CYP2C19 and voriconazole and a couple of SSRIs and CYP2D6. And so later on this summer we are adding T15. As Kelly said, the guidelines will be published a little bit later this summer. So our behavioral health group asked us to evaluate escitalopram for implementation because this was an important drug that we use to treat depression, anxiety, autism, and a number of other disorders. As we probably are aware, it's a selective serotonin reuptake inhibitor. It had high usage at children, so it made sense that we would consider it. It's prescribed actually by our primary care service as well as our behavioral health and developmental pediatrics. We had over 6,000 prescriptions in almost 1,700 individual patients. And we did use it in children less than 12 years of age. This is one of the off-label uses that we use, as the package labeling actually recommends to not use in children less than 12. Has a long list of potential adverse effects, some cardiovascular effects, dysrhythmias, dermatologic and GI effects, and even reports of serotonin syndrome. And so it made sense if we wanted to avoid the adverse effects associated with this that we would want to at least evaluate escitalopram for implementation. Escitalopram is a CYP2C19 substrate, and so mainly by CYP2C19 is converted to a less active metabolite and then further metabolized to an inactive metabolite by CYP2D6. Looking specifically at the CPIC recommendations for escitalopram, we focus mainly on the extremes of metabolism, so the ultra-rapid metabolizers and the poor metabolizers. With ultra-rapid metabolizers, the recommendation was to select an alternative drug not predominantly metabolized by CYP2C19. Poor metabolizers, the recommendation is a 50% reduction, and or to use a medication not predominantly metabolized by CYP2C19. Going back to those questions that I alluded to earlier, the Pharmacogenomics Oversight Committee had discussions, and thankfully the behavioral health representatives on our committee let me know that yes, we can expect the pediatric and adolescent patients to respond similarly to escitalopram for the disease states that we were treating. What is the gene that's important? We've already identified CYP2C19 as the primary enzyme that is responsible for escitalopram metabolism. And third question is variation in CYP2C19 associated with functional consequences in vivo. We've reviewed, again, mainly in adult studies. There were several papers that we looked at that had very similar graphs that demonstrated that poor metabolizers had much higher concentrations of citalopram and lower concentrations in the ultra-rapid metabolizers. A more recent study, this blue line also highlights that poor metabolizers have higher concentrations and lower ultra-rapid metabolizers have lower concentrations. But this is one of the first outcome studies I've seen where the sort of horseshoe-shaped graph represents the percent of patients or number of patients who actually changed therapy while taking citalopram, so they were not responding or were having toxic effects. And so we see a higher number of we had a higher number of patients who are poor metabolizers and a higher number of patients who are ultra-rapid metabolizers who changed therapy as they were from citalopram that were associated with their pharmacogenomic phenotypes. So we answered that question, yes, that there's functional consequences to genetic variation with CYP2C19. Final question was the developmental profile for acquisition of CYP2C19 activity. And from the slide I showed earlier, CYP2C19 activity should be reach adult values by the first year of age. So since kind of the youngest patient we had used it in was a 6-year-old when we did our review, we felt confident that we could apply the CPIC recommendations in a pediatric setting like this. So Pharmacogenetic Oversight Committee approved the implementation of CYP2C19 and citalopram. So in conclusions, drug metabolism is a rapidly changing and dynamic process from birth to adulthood. As I noted earlier, we need a better understanding, more information about dose, exposure, and response relationships in pediatric patients. Pharmacogenomics has its greatest utility. We have the best information with the drug metabolizing enzymes, and while I didn't address it here, the HLA genotypes, but that's been covered earlier as well. We can use pharmacogenomics in good ways to minimize the risk of adverse events in our patients and hopefully selecting medications that are more likely to be effective. With that, I'll take any questions.
Any questions for Dr. Gregornik? I can start out with one. So I get asked this a fair amount because parents are really interested in it, maybe more on the implementation side of things, but you guys had much internal discussions as to what to do with ADHD panels or pharmacogenetic recommendations for ADHD medications?
Right now, I'm actually, if I see them in clinic and their main concern is ADHD, I actually recommend that they wait for testing. As Kelly noted in her presentation, we have to have a recommendation that we can make if we're going to use this information, and really, I think based on the evidence, I can't make any decisions to try to choose between amphetamines or methylphenidate, or if I don't want to use a stimulant and go to like a second line agent. So if they have the information, I explain kind of what the results mean, but if they want to get tested, I actually say let's wait like one or 2 years and see if we can find any more information, and maybe there'll be additional testing that we can do at that time.
Yeah. So it looks like we've got 2 people. Why don't we start here and then go there?
I was just wondering if you know of any genetic polymorphisms that affect the rate of autogeny for any of those enzymes that we discussed.
That is a good question. I couldn't find any information that demonstrated that there are genetic variants that affect ontogeny. There may be, but again, we need more studies, and it's hard to get families to donate liver samples in a normal child. So.
Yeah.
Hi. So a hypothetical question. If you were to adapt a policy where you're going to genotype all patients a priori, like, is there a minimum age for which you should do a genotyping?
I don't think that there's a minimum age to do it. It's the application of the information. I don't think we need to do it as a newborn screening, but maybe a 1 year well child visit or something like that. I think by 1 year we have enough information that we could apply them.
All right, since we have a few minutes, I'm gonna ask one other question.
Sure.
So you included the list of medications you guys currently implemented. Are there any other, I guess, subspecialties within pediatrics that are kind of like more enthusiastic about implementing pharmacogenetic testing, at least within Minnesota Children's?
Well, obviously, due to TPMT and the thiopurines, our hematology oncology group was kind of the early adopters. They were actually already doing testing. We do try to preemptively test for TPMT and NET-T15 now in all of our ALL patients. And if we can get the full panel, then we can use all the rest of the results for supportive care. The hardest thing right now is getting coverage or getting insurance to pay for testing. I have had some minimal luck with our developmental peds and behavioral health patients getting their testing paid for. They have to be pretty medically complex for the insurance companies to pay for it, and unfortunately the families these are bigger dollar tests and would not. Or they're not able to afford it, but developmental peds and psych are really our biggest takers right now. We have had some inquiries from our pain and palliative care service, and we may be trying to look at doing something a bit more formally with our sickle cell patients who are kind of frequent flyers on the pain admissions.
All right, well, thank you, Dr. Gregornik.